Good morning. In my presentation today, I would like to talk about the beginning of blood pressure measurement, a little bit history, and mainly about the evolution of the guidelines of normal blood pressure. Before starting, I would like to thank Professor Kotsis for his kind invitation. Okay, so we start with a few slides about history of hypertension. And the first information about that is the Elvin Smith papyrus. It's an Egyptian physician named Imhotep that observed in 3000 before Christ that the pulse is the index of the heart and of the condition of the patient. Later, about 2600 before Christ, the Yellow Emperor Classic of Internal Medicine, a textbook at that time, said that the blood current flows in a circle and never stops. When the heart pulse beats vigorously and the strokes are markedly prolonged, the corresponding illness makes the patient unable to speak. Our understanding of the cause of stroke. If too much salt is used in foods, the blood vessels harden. In the 17th and 16th centuries before Christ, several Egyptian papyri not only counseled the examination of the pulse, but also direct auscultation of the heart as a source of the pulse. And Chu Yu-ai, a Chinese physician at 200 before Christ, wrote, when the pulse upon depressing is very firm and upon superficial palpation tight, then the disease has its seat in the kidney. Very interesting observation at that time. The Greco-Roman medical writings contain many references to apoplexy and hemiplegia, although hypertension as a cause was completely unknown at that time. Then during the period of Dark Ages, there was no much progress in the field. And we arrived to the 17th century with experiments of William Harvey. His revolutionary discovery of the circulation was the basis of later blood pressure studies. His famous book was published in 1668, but much earlier, in a lecture, he presented convincing proof of the circulation of the blood. In the 17th century, in 1694, Giorgio Baglivi of Rome reported the necropsy performed on the body of Marcello Malfighi. We know the Malfighi bodies, a famous physician of Bologna who discovered the capillaries. He died of apoplexy due to cerebral hemorrhage. He reported that Malfighi's death was probably secondary to renal hypertension. Baglivi stated the left kidney was free from any inflammation. The right was observed almost half as small as the left. In the 18th century, 1733, Stephen Hall of Cambridge, he was a reverend, not a physician, performed the first measurement of blood pressure and pulse pressure in a mare, inserting a tube to the left crural artery, and described the column of the blood was 8 feet, 3 inches of water, and the pulse pressure was 2 to 4 inches. In the later experiments, he measured also pulmonary pressure, venous pressure, blood volume, calculated velocity of flow in the arteries, and determined that capillary arteries were the site of chief peripheral resistance. Here are drawings published at that time, how we did the experiment. On the right, you see the crural artery measurement. On the left, carotid artery pressure measurement. 1828, Jean Poissel, a medical student in Paris, he devised the mercury manometer for measuring blood pressure and demonstrated respiratory blood pressure waves. He also later invented the plethysmograph and the Poissel law. Modifications of his manometer by Jules Harrison, 833, sealed the mercury with a thin membrane, and Carl Ludwig from Marburg developed the revolving chemograph to record the measurements. This is the Ludwig's chemograph. Looks complicated, but it's not so complicated. And on the right, this is the device developed by Mohammed, a prominent physician in England. Different types of sphygmomanometers. On the right, you can see the Marais sphygmomanometer was described as a handheld blood pressure measurement device. This is a von Bosch manometer. Looks complicated, but it's not very complicated. And it records the measurement. This is Mohammed, famous physician in England at that time. He wrote a book called The Sphygmomamograph. And here you see the picture. And was quite famous in the field at that time. The first clinically acceptable sphygmomanometer was designed by Scipione Rivarocci from Turin. This device measured systolic blood pressure by obliterating the brachial artery with inflatable rubber cuff. In 1905, Nikolai Korotkov, St. Petersburg, reported the auscultatory method of determining systolic and diastolic pressure, which became the standard method worldwide. In the middle, you see his explanation of the measurement. I think that many of us use this graph, at least I do, while teaching the students in medical school about understanding how blood pressure is measured. And then misconceptions, which were based on lack of knowledge. Paul Dudley White, very famous American physician, in 1931 wrote, "Hypertension may be an important compensatory mechanism which should not be tampered with, even where it's certain that we could control it." So we cannot control it anyway, but we shouldn't touch it because it's a compensatory mechanism. By the way, Paul Dudley White was a physician of President Roosevelt. He was the first in medicine that recommended physical activity, and he was jogging in the park near his house every morning, trying to give an example to all healthy population to do like that, to do like him. In 1946 edition of Thay's Practice of Medicine, a very famous textbook, leading textbooks, it was written, "May not the elevation of systemic blood pressure be a natural response to guarantee a more normal circulation? And overzealous attempts to lower blood pressure may do not good and often do harm." So many physicians thought that elevation of blood pressure is a symptom which its lowering will not cure the patient. Now, so we have a machine that can measure. It can be even portable, but what we do with that? Nobody knew what the meaning of the numbers is. And it is very interesting that among the first bodies that adopted blood pressure measurements as a routine were the insurance companies, which are among the first to understand the association between blood pressure, morbidity, and mortality. During the decade starting in 1907, more and more insurance companies demanded a recording of systolic blood pressure for every insurance policy. Routine blood pressure measurement for insurance policies became a general requirement around the year 1918. So everybody that wanted to have insurance, health insurance, after 1918, had to have his blood pressure measured. the knowledge that borderline blood pressure level is associated with increased mortality and morbidity was present already in the 1920s. At that time, blood pressure values and their association with morbidity and mortality accumulated mainly in the hands of insurance companies. These data were used for calculating the individual risk and cost of the insurance policy. So the higher the blood pressure was, the cost of the insurance policy was higher. Now, this is one of the first publications in this field about blood pressure of healthy men and women, published by Branded Simons in JAMA 1923. And not surprisingly, who was Branded Simons, MD? He was a chief medical director of Mutual Life Insurance Company in New York. So he had the data, he did the statistics, and he described the tables of normal blood pressure levels. Here, for instance, on the right, you can see systolic blood pressure for men. According, the columns are to build groups. We can call it today BMI, whether the subjects were heavy, thin, or medium. And on the left, according to age groups. So these data show in JAMA 1923 that the heavier you are, you have higher blood pressure. The older you are, you have higher blood pressure. Very interesting publications by Alvarez and Stanley, published in 1929. Alvarez was a physician from Rochester, and Stanley was the chief medical officer of San Quentin prison, very famous prison in America, in which the most dangerous criminals were imprisoned. And he had thousands of subjects and could measure blood pressure to all of them, and this is what he did. And for instance, here, it's not very clear, but you can see the changes according to body build, the normal or medium body build, and lower and higher. And it shows that guards in the San Quentin jail had higher blood pressure than the prisoners. Probably the guards were in stress, were in danger, etc. Here is another publication from the same paper, 1929, about changes in systolic blood pressure of white prisoners according to weights and the age groups. Again, statistics from the same publication. You can see that the peak of the wave, when you go up, moves to the right, which means the older you are, the higher your systolic blood pressure is. And here again, the effect of weight on blood pressure. Overweight subjects had higher blood pressures, underweight subjects had lower blood pressure. Okay, let's skip that. And John Hay, one of the famous physicians, published in BMJ in 1931, a review of significance of raised blood pressure. And in the next slide, we can see that there is a tendency of increase in both systolic and diastolic pressure in various age groups. Age of 20, systolic 120/75, 30, 123/79, etc., etc. So the older you get, the higher the blood pressure is, both systolic and diastolic. And here, table 1 shows us the risk. This was a basic table for insurance companies to calculate the cost of the policy. You can see, according to blood pressure levels in the middle, table 1, the column in the middle, elevations of blood pressure, and to the right, elevations in risk of mortality. So for instance, if your blood pressure was by 24 to 30 millimeters mercury higher than the average, and the average was 120, your risk for mortality was 2.14, doubled risk of mortality with levels of blood pressure which we today still consider as normal. This is a graph from the US Society of Actuaries, the United insurance companies, and the average risk of death is marked in red. So if your diastolic blood pressure is a little bit higher, between 68 to 82, you already have increased death chance. So the insurance companies knew it all 100 years ago. However, huge discrepancy existed between the insurance and the medical worlds. It is possible that the insurance data were not known to the medical world or they were disregarded. Insurance companies had many physicians in their service. So physicians working for insurance companies were aware of the increased risk of mild increases in blood pressure. Now, what happened in the medical world? Oh, sorry. In 1960, not so long ago, about 60 years ago, grade 1 hypertension was defined as 150 to 200, above 90 to 120. But in this group, the mortality, 5-year mortality was 30%. So how we can call it grade 1 hypertension? Grade 2 hypertension was significantly higher, and the mortality, 5-year mortality was 45%. The recommendations for grade 1 mortality was no treatment. Okay, in 1966, Friedberg, in his 1966 edition of Diseases of the Heart, wrote, in a patient with mild benign hypertension, it means blood pressure of below 220 over 100, there is no indication for use of hypertensive drugs. Very impressive statement. And the blood pressures up to this level were considered mild essential hypertension. Then the main explanation at that time was psychopathological personality. So the patient is anxious, the patient might be with psychopathology, etc. The definitions, patients were regarded as psychoneurotic, but some or most of the medical leadership had not yet gotten the message that these levels of blood pressure carry with them incredible risk. Okay, the studies that proved that it's dangerous, you probably know. And despite these facts, debate continued. Antihypertensive agents produced no obvious benefit in patients over 65. Fry published in 1974. So if you are over 65, no benefit if you give antihypertensive treatment, which is very strange for us to hear today. Or diastolic blood pressures of up to 120 millimeter mercury in symptomless elderly hypertensives are not an indication for therapy. So 120 diastolic, no indication for therapy. Hypotensive drugs should probably not to be given in the elderly unless the blood pressure is more than 200 over 110. This is an editorial in BMJ, 1978. Now, this is the last recommendation of the American Heart Association. And you can see normal is below 120 over 80, etc. You are all familiar with these definitions. And what we can note that this is exactly the numbers that were published 100 years ago by the insurance companies in the publications that I've shown you previously. Now, if you compare the JNC7 or the 2017 ACC American Heart Guidelines, the definitions of blood pressure, although different in the US recommendations and the European, if you look at the American recommendations, those are identical with those that were known 100 years ago. Okay, I think we have no more time, and I will conclude. Thank you.